Greetings and thank you for joining the Robert Wood Johnson Foundation's Systems for Action National Research Program, our regular Research in Progress webinar series. Today's edition of the S4A Research in Progress session is going to be fantastic. So I think you're going to be very glad that you joined us for today's session. For those of you who may be new to this webinar series or to the Systems for Action Research Program, let me take just a minute to introduce you to the program. Systems for Action is one of the Robert Wood Johnson Foundation's signature research programs, helping to build evidence to support the Foundation's strategies in building a culture of health across the U.S. And in particular, the Systems for Action program, we focus on studies that help us learn how strategies to better align medical care, public health, and social service delivery systems with the goal of improving population health and addressing both medical as well as social determinants of health. We know that as we look at strategies for improving health and promoting health equity on a population-wide basis, many of the issues that affect health and well-being and health equity exist far outside the medical care system. And in many cases, our medical care delivery and financing systems are not designed to interface effectively with broader social services and public health service systems. And so the research that we support through Systems for Action, all of these studies are testing different mechanisms for aligning and coordinating medical care systems with social and public health systems for a variety of different populations who experience fragmentation and disconnects in terms of the health, the constellation of health and social services and supports that they may need to be healthy. Systems for Action, we sponsor a variety of studies testing these different system alignment mechanisms for various population groups and in various types of settings across the American health and social service systems. Today, we are going to hear from one of our research teams and research projects that are based in North Carolina. Based in the Durham Veterans Affairs Medical System, and including a research team that includes collaborators at Duke University as well as individuals who are affiliated with the Denver Veterans Affairs Medical Care System. In particular, we'll be hearing today from Dr. Megan Shepherd-Banigan, who is a health services researcher, completed her PhD in health services research at University of Washington. And she focuses a lot of her research on studying family support for individuals with mental and physical disabilities, and looks at a variety of ways for for supporting rigorous research on studying those populations and how to best meet their needs, including tackling issues around how to best build health systems that can support the needs of those populations, particularly veterans populations that face those issues. We'll also, Megan will be joined by her colleague Jennifer Henius, who is a licensed clinical social worker with a long history of experience in working with veterans and in Veterans Affairs health systems. Jennifer completed her master's degree in social work at University of South Florida, and also has done completed work at the VA's Graduate Healthcare Administration Training Program that is focused on developing high-performance leaders for careers in healthcare administration. And so we're going to be hearing about their research project, which focuses again on veterans and in particular strategies of supporting family support and informal caregivers in the role of helping to connect and meet the health and social service needs of of veterans populations. So with that, I am going to turn it over to Megan and Jennifer to step us through their research project and tell us what they're learning.
Great, thanks so much, Glenn. This is Megan, and I want to thank everyone for joining us today. I'm going to be discussing the final results from our Systems for Action project called Integrating Health and Social Services for Veterans by Empowering Family Caregivers. Last July, I actually presented a work in progress on this project and presented preliminary results from the rapid qualitative analysis that we did. And for the quantitative aim, I presented the results from one of the outcomes. But today we've got the full results available, so I'll be speaking about the results that are actually in the process of being written up and disseminated now. To begin, I'd like to acknowledge our team and partners, particularly the VA CARES evaluation team that's directed by Dr. Van Houten. And I'd like to also acknowledge our partners in the Caregiver Support Program Office in Central Office VA, and particularly thank you to Jennifer, who will provide some remarks at the end of this talk. Okay. Trying to figure out how to, okay, here we go. All right, so just an overview of the presentation. First, I'll discuss the context and the problem. Then I'll talk about how caregivers can be a potential strategy to address this problem. I'll discuss both of our research questions. I'll talk briefly about the methods and then about the findings. The first research question is a qualitative project that explores how caregiver support facilitates veteran engagement with both medical and vocational education services. So again, here we're talking about both the medical and the non-medical sector. Research question 2 is a quantitative aim, and we examine whether institutional support for caregivers that's provided by VA impacts veteran time to use of 3 vocational and education services, specifically the post 9/11 GI Bill benefit, vocational rehabilitation and employment, and supported employment. I'll then provide some conclusions from this research, discuss some practice and policy implications, and then Jennifer Henius, our partner from the VA Caregiver Support Program Office, will provide some remarks. So the context. Since 2001, 3.3 million troops have been deployed. And due to advances in battlefield medicine, many folks are now surviving injuries that were once fatal, and they're returning home. So they're returning home with high rates of conditions such as PTSD and traumatic brain injury, or TBI. And for some veterans with these conditions, some may experience reintegration challenges, such as maintaining social relationships, maintaining employment, engaging in education. These issues can lead to economic vulnerability and to ultimate declines in health. So the context is that we've got a veteran with cross-cutting medical, social, and economic needs. And within VA, we've got several ways to meet those needs. VA is exciting because it's one of the few systems that provides not only health, but also non-health services to really meet these integrated needs. First, we've got the Veterans Health Administration, or VHA, that offers evidence-based medical and psychological care. VHA also offers a program called Supported Employment. This is an evidence-based program that was originally developed for individuals with serious mental illness, and within VA has been adapted to meet the needs of veterans with both traumatic brain injury and PTSD. The goal of supported employment is to find and maintain competitive community-based employment. Studies about supported employment show that it's associated with competitive work attainment, longer job tenure, higher income, and increased days of paid employment. In other words, supported employment has been shown to meet some of the social and economic needs that individuals with serious mental illness and disability have. VHA also provides institutional support for caregivers through the Caregiver Support Program Office, and I'll discuss what this program is in detail later. VA also has the Veterans Benefit Administration, or VBA. VBA offers education assistance through the post 9/11 GI Bill that was established in August 2019. Vocational Rehabilitation and Employment, or VR&E, offers career guidance services to seek jobs, and they also provide education assistance with the goal of securing employment. Past research indicates that the post 9/11 GI Bill drives veteran decisions to pursue higher education. And furthermore, studies about the pre-9/11 GI Bill, or the Montgomery GI Bill, suggested among Vietnam-era veterans, VA education assistance was related to a modest increase in income. So again, this program has been shown to address some of the social and economic needs of veterans. Within VA, we also have a lot of great data systems. I think what's been challenging, however, is that these data systems are not integrated. And so, while we argue that we need integration to fully meet these comprehensive needs of veterans, and we've got VHA and VBA that offer services to meet these needs, the delivery of these services is compartmentalized within distinct VA bureaus and across different program offices and also different data systems. So these challenges impede the development of coordinated approaches to actually delivering integrated care across sectors to meet some of these cross-cutting needs that veterans have. And the issue is that lack of sort of this integrated care can inhibit veteran recovery and lead to long-term financial, social, and health consequences. So incomes are proposed strategy. Increasingly, family caregivers, particularly among geriatric populations right now, are recognized for their potential to coordinate care and advocate on behalf of their loved one or the care recipient. And so we hypothesize that the family caregiver, because of their intimate knowledge of the veteran's needs, can serve for some care recipients as a really important coordination factor between services offered by VHA and VBA. Further, as we've got institutional support for caregivers, we hypothesize that having trained and educated family caregivers with knowledge of VA has the potential to activate key drivers of health and social system integration. Some of our own research within the VA Cares Evaluation Center has actually shown that institutional support for caregivers increases veteran use of outpatient services. However, we don't know whether this institutional support for caregivers extends to non-medical services, and we don't actually know why this happens. We don't really understand what functions family caregivers are playing to help achieve this, this end. So essentially, we're saying that family caregivers are well placed to provide these coordination advocacy tasks, and with institutional support, their capacity could be increased such that they could become a cross-sector alignment mechanism. And within VA, there's a lot of opportunities. In 2010, Congress passed the Caregivers and Veterans Omnibus Health Services Act that outlines specific new services that VA provides to caregivers. The first is the program of general caregiver support, which is for caregivers of eligible veterans from all eras who need a caregiver due to ADL limitations. The second program, and the one that we're going to focus on today, is the Program of Comprehensive Assistance for Family Caregivers, or PCAFC, which is for caregivers of eligible veterans injured in the line of duty on or after September 11, 2001. So through both of these programs, caregivers have access to a caregiver-specific point person within VA, or a caregiver support coordinator, and to free caregiving-related trainings and education programs. PCAFC offers expanded services, most notably a monthly stipend, health insurance, mental health care, and enhanced access to respite care. And just as, to remind you all, PCAFC is also only targeted to caregivers of veterans who were injured post 9/11. programs are administered by the VA Caregiver Support Program Office that's housed in the VHA under Care Management and Social Work Services and Patient Care Services. So another exciting thing within VA is that Congress passed the VA Mission Act in 2018. And one provision of this is to end the disparity of limiting the PCASD to caregivers of post 9/11 veterans only. So in other words, expanding eligibility to caregivers of veterans from other eras. Changes through the Mission Act to PCASD also newly authorized financial planning and legal services as additional VA benefits that will be provided to qualified caregivers. So just to recap, we've got the problem is that some veterans have complex health and social needs that can lead to poor outcomes. A potential strategy is that family caregivers can help to coordinate across program offices and VA bureaus to help veterans access the services they need to meet their cross-cutting needs. Within VA, there's opportunities. VA offers robust national support for family caregivers that can enhance their ability to coordinate care across sectors. Further, as I sort of alluded to earlier, there are data sources, there are administrative data sources both within VHA, VBA, and the Caregiver Support Program. They're not merged. And so through our partners, we were able to get access to VBA data, which really hadn't been done by many researchers before, and then we were able to link the VBA data to the electronic health records, or the VHA data, and also the Caregiver Support Program Office data to get information about family caregivers. So this led us to be able to address these research questions. And again, the first one is a qualitative project where we're really interested in getting at that question of what is it that family caregivers are doing to increase veteran access both to medical and non-medical services? And research question 2 is a quantitative aim where we're extending some of our previous work done on outpatient healthcare to understand whether institutional support for family caregivers through PCASD can impact the use of these employment and education services. And we're specifically interested in the post 9/11 GI Bill, which is an education assistance program, vocational rehabilitation and employment, which also provides career services and education assistance, and supported employment, which was that evidence-based project to help folks with disability find and maintain competitive work in the community. So I won't throw you all off too much, and we will talk about research question 1 first. So we conducted 26 joint, in-depth telephone-based interviews with veteran and caregiver dyads. So this means that we actually interviewed caregivers and veterans together. Our sample included dyads in which the caregiver had enrolled in PCASD at some point, and veterans who had used at least one of our employment or education services of interest. Now, the reason that we constrained our sample to be people who'd only used PCASD is that through that we were able to easily identify a family member who was engaged and who had been identified as a caregiver. So we were trying to really understand, obviously if someone needs a caregiver, they've got a certain level of disability, and we were really interested in that population. So by using this data set to identify participants, that helped us identify the caregiver and the care recipient, type of care recipient that we were looking for. Once we conducted the interviews, we did a thematic analysis where we started with structural coding. So we coded based on some of the questions in the qualitative script. We then conducted content coding, which was a little bit more of an emergent process. So there we sort of looked at to see what sort of themes were emerging. We summarized themes across our cases. We did analyze the veteran and the caregiver as a unit. We did it as a dyad. We didn't really look at discrepancies between the two. And then we conducted extensive checks for coding consistency. So now I'll discuss some of the themes, some of the findings that came up. So here are some descriptive statistics of our qualitative sample. Recall that we had 26 dyads. The mean age of the veteran was 42 years. The mean age of the caregiver was 39 years. 100% of veterans were male and 100% were female. 64% of the veterans were white, and 85% of the veterans and caregivers were married. 65% of the veterans in our sample reported using the post-11 GI Bill. 58% had used VRNE. It was challenging to recruit people who had used supported employment for several reasons, so we didn't have too many of those folks. Interestingly, we had a lot of people who had used at least 2 of these services. Most of the veterans that we talked to were pretty committed to engaging in these vocational and education services. And for some, it was a means for employment. Some of these veterans, on the other hand, though, were really looking to find something more enriching and fulfilling in their lives, and this was a mechanism that they saw to do it. So for a lot of them, it was an improvement in quality of life. So one of the most interesting things that came up was that veterans described their recovery as encompassing both health and family, and employment and education needs. All of these folks had engaged in the vocational and education services, and they felt that as a result of participating in these services, they grew new skills. And again, these might be vocation-specific skills, but for some people, it was skills around things like digital photography or animal behavior, things that they felt would give them pleasure and meaning in their life. For many veterans, it was an opportunity for increased socialization and particularly interaction with non-military populations. A lot of the veterans felt that upon returning home, they needed practice engaging with the civilian society, and so these programs gave them that opportunity. Many also talked about increased self-confidence, and together they perceived that some of these benefits actually led to improvements in their health. For example, one veteran said, "For me, it was therapeutic. I believe that something like that will help a lot of veterans that suffer from PTSD." However, there was a sense that there was a lack of interaction between VA bureaus, that participants felt inhibited VA's ability to address these cross-cutting needs. So that was sort of what we were getting at early in the presentation. There's just a fragmentation and a compartmentalization of services, between bureaus and then across program offices. Participants observed limited interaction between VHA clinical healthcare teams and VBA employment and education counselors. And then folks also talked about how they felt that there was a lack of understanding on the VHA side about how to access VBA services. And one caregiver describes this nicely in this quote. She said, "There is a disconnect between the service side, the benefits side, and the VA healthcare side. Healthcare providers, the admissions, and the benefits counselors focus on theirs. So they might know of other services, but they wouldn't know how to apply or the details of the program." Another really interesting part of this project is that we were able to identify the specific supportive tasks that caregivers provide that help veterans engage in VA services. So some of these tasks included instrumental support, emotional support, coordination, advocacy, and informational support. For those that are familiar with social support theory, you may recognize some of these constructs. We did start with social support theory as a foundational theory to build some of the interview questions. And so we found that some of those foundational aspects of social support, such as instrumental support, emotional support, informational support, were present. What was interesting is that we also identified coordination and advocacy as being also critical. And so we found that while caregivers support veterans to engage in both healthcare and vocational and education VA services, they were more involved in helping veterans to access health services. We did find that the types of tasks that caregivers provided were similar across the health and non-health domains. Some of the most interesting discussions that arose with participants were around instrumental support and coordination and advocacy, so I'm going to delve into those a little bit today. So examples of instrumental support that caregivers provided included driving veterans to medical appointments, registering them for classes, helping them to complete homework assignments, and then completing paperwork for VA benefits or school disability services. Instrumental support was fairly widely cited across both health and non-health sectors. Caregiver coordination tasks encompassed reaching out to VA providers, professors, and disability services to help streamline the process of applying to and attending school. It also encompassed, reaching out for specialty services, engaging with pharmacies, and really helping to bring together all the pieces that are needed for veteran healthcare. So one caregiver talked about this. She said that one of her roles was informing providers of progress at home, how he's doing mentally, how he's doing physically, and then letting them know the side effects and anything that is going on with the medications that he's taking. Caregivers demonstrated a high level of skill in coordinating health-related services. And while some caregivers played a role in helping veterans to coordinate the vocational and education services, we actually found that veterans themselves did a lot of that groundwork, and that caregivers tended to step in when the veterans either became frustrated or sort of indicated that they needed some support. So given the cognitive challenges that some veterans in PCASD have, and then their need to interact with civilians in work and education settings, which can be challenging because oftentimes civilians are not educated about military culture, and they lack insight about veterans' needs. And so because of this, having a caregiver who can effectively advocate is essential. Caregivers talked about how they would speak up on behalf of the veterans to clinicians or professors and advocate for their needs. For example, one caregiver talked about her advocacy in the academic setting. She said, "I was able to help by going to the registrar's office, going to the special services department, and ensuring that everything was handled and the professors were aware that he isn't a joke, and he's here and he wants to be taken seriously. But it's more than just the arm that's missing. It's the intellectual and emotional disabilities that affect these veterans more because it's harder for us able-bodied to recognize the difference." So she talked about several layers where it wasn't just the disability, both the seen and the unseen disability. There was another level where civilians not sort of understanding the reality that some of these veterans come from just add another level of difficulty to that challenge. So caregivers demonstrated a strong set of skills to provide essential supported tasks to help veterans navigate and access VA health services. However, the role that they played in helping them to educate, to engage in some of the non-health services and to coordinate across health and non-health sectors did not seem to be embraced in the same way. Participants seemed to indicate that it was perfectly acceptable and expected that caregivers would engage in this way in the health sector, but there was less certainty around their role in the non-health sector. So as part of this project, we also examined whether institutional support for caregivers through PCASD might be able to help them bridge the gap between health and vocational and education services. So I'll discuss some of those findings now. So critical elements of institutional support for family caregivers that was key for improving veteran use of health care included first providing a point of contact. The caregiver support coordinators that I alluded to earlier linked caregivers to respite care, disease education, and caregiver skills workshops. They also helped to directly facilitate veteran care when veterans and caregivers ran into roadblocks trying to access specialty care or getting prescriptions filled. simply because they were a point of contact that caregivers knew about in the system. Financial assistance through the stipend allowed caregivers to devote more time to facilitate and coordinate the veterans' health care, many of whom expressed that it was a full-time job just to do that. And then lastly, both the veterans and the caregivers talked about how the designation of being a PCASD caregiver legitimized the caregiver's role in the eyes of the healthcare team and really helped to facilitate the caregiver's role in supporting the veterans and getting them access to healthcare. We saw fewer examples of how PCASD engagement helps veterans to engage in vocational and education services. The stipend, allowed some folks, again, more time to help engage with professors and help veterans with schoolwork. Many veterans, a couple of veterans also actually talked about how they learned about the vocational and educational programs from the PCASD staff. One of the caregivers talked about this, and she said that one of the nurses there from the PCASD program was saying, well, you could do something for yourself and you could go to school. So this encouragement from the Caregiver Support Program staff actually did help to motivate some folks to start thinking about school or some of the vocational training programs. So in conclusion, veterans perceive that participating in employment and education services does improve their health. And so one question that we'll get back to a little later is, are these services, particularly in VA that offers these services, does it make sense to include these services in patient health treatment plans? Also, we saw a lot of evidence that caregivers have the capacity to operate as a bridge between health and non-health services. They're already carrying out these tasks in the healthcare setting. And so it's really thinking about how to directly translate these tasks to the vocational and education setting. So we are right now are seeing less of that occur. Caregivers are also very well positioned to communicate with clinical teams. And so that's sort of another sort of piece that helps them operate as that bridge. We found that institutional support for caregivers has clear impacts on healthcare, but again, it's just thinking about how those impacts could also be extended to go beyond the health sector. So now I'm going to talk about research question 2. As you may recall, this is a quantitative aim where we were looking at the effective participation in PCASD on time to use of 3 employment and education services, the post 9/11 GI Bill benefit, VRNE, and supported employment. So as I had mentioned earlier, we were able to access data from the VHA, which was the electronic medical records, the Caregiver Support Program administrative data that provided us with contact information and some demographics about the caregivers, and then also VBA administrative data that contained information about the post 9/11 GI Bill and VRNE. I should note that information about supported employment actually came from the medical records because there is a clinical code in VA under VHA for these services. We had 3 samples. We had 1 cohort for each service outcome. Within each cohort, we included veterans under 55 years old whose caregivers had applied to PCASD between 2010 and 2014. And the reason that we chose veterans under 55 is because we reasoned that those over 55 might be less likely to look into vocational assistance programs. We did exclude veterans in each cohort if they had used the service outcome of that cohort prior to PCASD application. So for example, veterans in the GI Bill cohort, where we were looking at GI Bill as an outcome, if they used the GI Bill before they applied to PCASD, they were excluded. Our control group was caregivers who applied to PCASD and were never approved for enrollment. So there, we were actually able to use a new method that's been recently developed. So So we used an instrumental variable Cox proportional hazards regression model. And the citation for that new method is here. Treatment was whether folks had ever been approved and had at least 3 months exposure to PCASD. The outcomes were time to application for each of the 3 employment education services. The instrumental level variable was facility level percentage approval for PCASD in the 6 months prior to PCASD application. And so we reasoned that this is a more indicative of practice style at the facility level than individual level characteristics. So we thought that it would be a more valid IV. And as a sensitivity analysis, we also ran the naive adjusted Cox proportional hazards regression model, which simply means that we ran the Cox model without the IV. Both were adjusted for the covariates that we had available. So some of you may have some red flags going up when I talked about the control group. We were unable to randomize individuals to PCASD because this is a national program. And we are assuming that folks that are enrolled in PCASD versus not, that there's a non-random selection, that they're different from one another, and that the relationship is confounded by unobserved factors that we can't control for. So for example, individuals who are accepted into PCASD might have unobserved characteristics that also affect their use of these vocational services. And one of those things could be a taste for work. So personal expectations for engaging or work or school could be related to PCASD selection and use of vocational services. So for this reason, we were worried about unobserved confounding. And essentially an IV, I'm not going to go into the details of IV here. I'm happy to speak to anybody about it afterwards. But essentially an IV allows an analyst to pseudo-randomize or sort individuals into groups such that their characteristics are balanced across treatment groups. Okay, so now I will present the descriptive statistics. So in this table, you see some descriptive characteristics. The paper will have a lot more comprehensive table 1. But in the first row, you can see the number of people that were included in each outcome cohort. You might notice that supported employment is much higher than the others, and that's because the use of supported employment was so low that there were so few people who used supported employment prior to applying for PCASD that they were then eligible to be in our cohort. The second row is also very interesting. The highest within these cohorts, almost 20% of folks eventually used VRNE, close to 15 ended up using the post 9/11 GI Bill, and about 2% ended up using supported employment. And again, I'm happy to talk about reasons for that. Another interesting thing is that characteristics are fairly similar across these 3 cohorts. Veterans were mid-30s, about 90% were male, about 70% were white, about 11 to 12% were Hispanic, about 80% of caregivers and veterans were married or partnered. Rates of PTSD, or the prevalence of PTSD is quite high, almost 70%. Almost 30% of folks have a documented TBI diagnosis, and these came from medical records. And then musculoskeletal disorders and disease were also very common. So you can see this is a young group of folks with a lot of health problems, and you can see why they would need caregivers. So now I'll talk about the analytical model results. So I'm going to discuss assumptions, and first I'm going to discuss the proportional hazard, the Cox proportional hazards assumptions. The assumption is that you're assuming that there are parallel trends between the treatment and the control group, and you can look at this using unadjusted Kaplan-Meier curves or survival curves. So we actually found that our data did not violate this assumption. We also examined assumptions related to the IVs. So for IVs, they need to be strongly associated with the treatment variable. And you assess that in the first stage equation. And across all of our 3 cohorts, we had a sufficiently strong IV or an partial F statistic of over 10. The other important IV assumption is that IVs need to be valid. And so the reason that you're doing the IVs is because you assume that covariates are imbalanced between treatment and control, and that particularly for those covariates you can't control for, that imbalance will remain after you adjust for all of your covariates. And so the idea with the IV is that covariates should be more balanced across levels of the IV than they are across treatment and control groups. Of course, this is untestable because if you don't have the covariates, if they're unobserved covariates, you can't see the balance, but we try to test it by looking at whether balance is improved with observed covariates. And again, across all 3 of our samples, the large majority of covariates achieved a greater level of balance and an acceptable level of balance that we looked at using standardized differences across levels of the IV versus the treatment and control group. So we felt like we had a strong IV and we had some thought that we had a valid IV, because if you're seeing these greater balance across observed, you're assuming that you would also see greater balance across unobserved. Again, we can't test that, but it looked good. So here I'm going to be presenting the hazard ratios for all 3 outcomes. And I'm going to be presenting both the hazard ratio from the naive adjusted Cox model and the IV adjusted Cox model. The IV is our primary analysis, and so those are the results that we're going for. So you can see a hazard ratio of 1 indicates no difference. A hazard ratio less than 1 suggests that that the control group might have been accessing these services more. But we saw no statistically significant effect for the post-9/11 GI Bill. And no effect in the IV model for VRNE. Supported employment, however, across both the naive and the IV models did suggest that there was that being in PCASC led to a 35% greater rate of engaging in supported employment. Interestingly, the point estimates across the naive and the IV models are fairly similar. And you can see IVs tend to be inefficient estimators. And so you can see that the confidence intervals are wider for the IVs. And so sometimes you won't see effects because of these wide intervals, but for supported employment, despite the low use, we are actually seeing effects. So again, for supported employment, the IV model, the hazard ratio indicates that folks whose caregivers were in VA had a 35% higher rate of using supported employment. So the conclusion for this is PCASC seems to be associated with the use of supported employment. And the next question is, well, why? And so based on some of the, this wasn't a mixed method study, but sort of some of what we gleaned from the qualitative, we're wondering whether it's possible that linkages between supported employment and PCASC are more direct, possibly because they're located within the same bureaus. So supported employment and PCASC are both within VHA. So, so maybe caregiver support coordinators knew about supported employment and were able to help get veterans referrals or able to talk to the caregiver about it. It's, we're not exactly sure, but that's one hypothesis. So these are now the implications for both of the aims, implications for practice. Caregiver support for employment and education services aligns well with PCASC's orientation towards recovery and psychosocial rehabilitation. That is to say, PCASD's orientation towards recovery is really thinking about how some people may become more independent. However, others, it's just thinking about incremental improvements in quality of life. And so the idea of having caregivers support these services does align well with PCASD's orientation. And in terms of thinking about how to translate these findings into practice, could VA or PCASD develop tools or information that could help caregivers navigate VBA services? As I'd alluded to before, thinking about how treatment plans can be more comprehensive to actually address employment and education needs, to think about what these needs are. Can they be part of treatment goals for veterans? And then another idea is it possible for PCASD staff to strengthen their relationships with VBA programs? I think you'll hear a little bit about this from Jennifer. And then thinking about implications for policy. So it's going to be important to define employment and education as priority determinants of health in VA. I mean, right now they're very, very separate. And so what can we do to, have those bubble to the top as being priority determinants? We are also suggesting that it would be good to extend work being done to involve caregivers in healthcare teams, to involve caregivers in, some of the VBA service teams as well. And then thinking about how to shift perspectives around the role that caregivers can play, both in the employment and education sector, and then also for their ability to perform cross-sector coordination. And to do this, it's going to be important to educate providers, VBA counselors, caregivers, and veterans. So that is it. And now I'm pleased to have Jennifer provide some remarks.
Thank you. Thanks so much, Megan, and thanks for your important work on this project. And thank you to the Colorado School of Public Health and the Robert Wood Johnson Foundation for including us as the operational business partner in the discussion today. Our collaboration efforts with the Veterans Benefits Administration through this project has really been helpful in terms of providing us with a variety of rich data points that help us to better understand the characteristics of the population that we're serving. The post 9/11 program, the comprehensive program, is a clinical program that's really designed to support the veterans' biopsychosocial recovery and rehabilitation to the extent that's possible. And although not everyone on the program is going to be able to transition off our program, there will definitely be veterans who are capable of recovery to the extent that they're able to transition back into the workforce in some sort of capacity. So these veterans may not be able to transition into careers similar to those that they held previously in the military, and so they might need to think about exploring continued education and VR&E and different opportunities to develop new skills. The veterans, as you heard, are also using the GI Bill really to address quality of life issues that are tied to recovery, like adjusting to their new place in society or gaining a new sense of purpose, because so many veterans define themselves in their military experience. And so this gives them a new opportunity to really reinvent themselves and allows for a new opportunity of learning. And it's also a form of social engagement for our veterans who might otherwise be more socially isolated in their interactions and with their relationships. So as Megan describes, not just about the completion of degrees or trainings that's beneficial, but it's also the academic environment and all that comes with being, on campus and in part of that social environment. So we really need to educate our staff in these findings and raise awareness to the impact of these services and how they can improve one's health and their overall well-being. And if you consider the findings of the types of health conditions for the veterans on our program, most notably, many of them are suffering from post-traumatic stress. And the bottom line is that this, that recovery is possible, right, with the right evidence-based therapies. So we need to consider how employment and education can serve as resources for support. And there are things in place now to help veterans help their educational experience be more successful, like allowing pet therapies in the classroom, enabling more opportunities for breaks, allowing extended time for test taking and things like that. The veterans and caregivers in our program, through the caregiver support coordinators, they have a dedicated clinical resource, and most of these positions are filled by social workers and registered nurses who don't typically address the benefits and services provided by VBA. As Megan indicated, we are pretty siloed, and these are huge departments between the VHA and the benefits side. But certainly our staff members can engage in discussions with veterans and caregivers about the available resources and benefits, not just provided by the healthcare system, but we can also sort of serve as a source of support and encouragement to consider all the tools that the broader VA makes available to them. So some of the things that Megan said, like what are the simple tools that we can do? Well, we can provide fact sheets on services provided by benefits, flyers, we can update our website. There are some really concrete things we can do. We've already collaborated on an outreach activity with VBA and AARP on an outreach event that was sort of like a virtual caregiver fair, but VBA and VHA were at the table together to address questions from caregivers. So I think that's a step in the right direction as we think about providing wraparound services. Another huge effort that we're undertaking right now, because of the Mission Act, we've been really fighting for IT dollars, and so we were able to receive some of that funding as we look to expand our program. And one of the things that we noted as a business need is to improve data visibility across the VA enterprise so that we can more easily identify who these caregivers are across the system and their relationship to their veteran sponsor. And then that will help us better understand what services caregivers might be leveraging from the benefits side, and also give the benefits side a heads up of which veterans on the VHA side are participating in our program so that we can make better connections and just understand the resources being utilized and any gaps that we could try to leverage. So that's a huge win, I think, for our departments, just having the visibility and that information sharing. That concludes my remarks.
Thank you so much, Jennifer. Okay, so I had very quickly, I just wanted to give a slide on some of the dissemination that we've done. It's there if anyone wants to look at it. Additional resources related to what we've been talking about today. And I wanted to thank everybody again for being here, and also thank you so much to the Robert Wood Johnson Foundation and Systems for Action for the opportunity to do this work. There's just not a lot of opportunities to get this funded, and we are very, very grateful. I'm happy to take any questions now, and here's my contact information.
Fantastic. Thank you so much, Megan and Jennifer. This was really interesting work. Great to get another glimpse of the work that you're doing, the findings coming out of this project. I know we've got just a few minutes left, so I do want to go right to some questions if we can, and encourage folks who are with us on the webinar. If you've got a question that you'd like to submit, there's a Q&A box down at the bottom of your screen. If you're with us on the online portion of today's webinar, you can use that box to submit your questions. I do see that we've got one question submitted asking, this is the question about the quantitative analysis that you presented, the second analysis that Megan presented, that was looking at the time to accessing education and employment support services. You mentioned a naive model. There's a question about can you say more about that naive model that you examined? I guess the model that did not include the instrumental variables.
Yeah, exactly. I mean, that model, so that was just a normal Cox proportional hazards model that you might run that included all the covariates. The instrumental variable model is a two-part model where you, well, it's a lot of detail, but basically it's sort of the typical model that you would see if you were just doing a regular Cox proportional hazards model. I don't know if that answers the question, but.
Fantastic, thank you. And Another question, slightly kind of bigger, more conceptual question. So this project has done some great work both qualitatively and quantitatively to examine the role of caregivers in helping to connect health and social services for veterans. And you've shown some pretty compelling evidence both qualitatively and quantitatively. There's a strong role for caregivers, and that this caregiver support and training program can also really support caregivers in playing that role in bridging health and social service sectors. I wonder, do we know much about the burden that's created for caregivers when they're playing that role of not just coordinating health services, but now as we're trying to position them for playing a larger role in both interfacing with the non-health services as well. Anything that we learned from your project or other research about the burden on caregivers that cross-sector role might generate?
That's a great question, and it's something that we have actually grappled with a lot as a team, because heaven forbid we add more to their plate, because these caregivers are very overwhelmed. For the caregivers, it's interesting. The caregivers right now who were taking on that, I think were taking it on because they felt that they could, and so I would anticipate that the burden would increase if it was something that expectations changed and that was something that caregivers were sort of expected to do. So our participants did not talk a lot about the added burden, simply because I think those that could do it did do it. I think sort of when thinking about some of the kind of ethical things about what you're putting on caregivers' plates, we reason that there is there is a big incentive for caregivers to help with this sort of thing, because it does potentially help household income, it does potentially improve the veterans' quality of life. And so when you're thinking from a family systems approach, while there's an added burden, we would be expecting that there's also benefits. But that's definitely something that needs to be taken into consideration, and I really appreciate that question.
Fantastic. Thank you so much. And I know we're just about out of time, so I want to again thank our panelists for today, Megan Shepherd-Banigan and Jennifer Henius with the Durham VA and the Duke University research team. Great work in helping us learn some very important lessons about how to align health and social services for veterans populations. I hope that we'll see more work and more studies that we can support in the future, looking at this very important population group, our veterans and their families, and looking at ways of better connecting systems for this group. Do encourage you to stay tuned for upcoming research in progress webinars from the Systems for Action program. We do this webinar series every 2 weeks, featuring a new study. So please stay tuned for upcoming webinars. You can access all the information about not only webinars, but all of the research projects that are operating under this program. Their papers and presentations and emerging findings are links to those resources go up on our website. So encourage you to visit systemsforaction.org as well for the latest on these projects, as well as upcoming funding opportunities. We do anticipate releasing a new call for proposals for new research projects to be supported under the Systems for Action program, releasing that call later this fall, actually in another couple of weeks. So so stay tuned to our website for funding opportunities as well. Thank you so much for joining us, and we will sign off for now. Thank you so much.